Sir, and Dr. Enamal H. Milton Sir, our Scientific Secretary Dr. Smruti Hota Ma'am, our Workshop Coordinator Dr. Hari Podal Sir. They have all been on a roll since the last ICRAPAIN to bring to you all an academic fest and collectively came to a conclusion that how a basic tool, musculoskeletal ultrasound, holds a crucial role in making the diagnosis of n number of conditions that are usually shunned in day-to-day practice and just prescribed with NSAIDs. It is their knowledge of subject, knowledge of lacunae, and the insight of doing better as physicians is what that led to the theme of ICRAPAIN this year, that is musculoskeletal ultrasound in pain medicine.
Their amazing teamwork, patience, knowledge, and a vision is the result that we are all experiencing here today in this hall. I request the whole committee to come forward on the stage and light the lamp of knowledge. And I wish that each one of our lives are always filled with light and joy. I also request our fellows, Dr. Pushpak, Dr. Deepak, and Dr. Hemalata to join us on stage. Kindly light the lamp, sir and ma'am.
Thank you, sir and ma'am. Now we'll all stand for the national anthem. Please play the national anthem. I would like to request the audiovisual team to play the national anthem now.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Jai Hind. Now I would like to call Dr. Gautam Das sir on stage to share his thoughts and vision with all of us and to declare the meet open.
First of all, I want to thank all the faculty who have taken pain to come, wasting their time, wasting their practice. So thank you very much for coming. And also for the delegates, whoever is here. So our heartfelt gratitude and thanks to all of you. Over the years, earlier, as we were mentioning, that we was having a very, the gorgeous inaugural ceremony. But gradually we understood that we should be appreciating our team members' effort. And that's why you have seen we have not invited any special dignitaries, and the honor should go to our team members who have given all the hard efforts to make this conference successful. So a big clap for all of them. So without delaying further, we want to go straight to the scientific program. And after this inaugural program, we'll be dividing into the hall A and hall B. This hall will be having the live scanning session, and the other hall will go with the degenerative medicines. So thank you again for all of you to come and join this conference. Thank you all.
Thank you, sir. You are our constant pillar of strength.
I would like to welcome all of you again with a Bengali touch. Suprabhat Shushwagatam.
Taking no time further, let's begin with our first session of the day. Hall A subject will be live scanning. Hall B, we have the regenerative medicine part. You can join us in either halls.
The hall B is the adjacent one. Thank you.
Good morning, everyone. I'm Dr. Priyanka. I'd like to welcome you all for the much-awaited session, MSK Ultrasound Live Scanning. In this live scanning session, we bridge theory with practice exploring musculoskeletal anatomy as it unfolds under ultrasound guidance. The chairpersons for this session are Dr. Rita Paul, a highly respected pain physician admired for her commitment to advancing interventional techniques, and I also like to welcome Dr. Varsha Kurade, known for her expertise in ultrasound-guided interventions and dedications to medical teaching. And I also like to welcome Dr. Varsha Kenya, professor and head from Bharati Vidyapeeth, Pune, an inspiring pain physician, teacher, and researcher. We welcome our chairpersons now. Talks under this session, that is for 15 minutes. The topic is the shoulder, Dr. Madan Pandyan. Please welcome Dr. Madan Pandyan, who will demonstrate ultrasound scanning of the shoulder. Dr. Pandyan is recognized for his precision and excellence in musculoskeletal imaging.
Good morning, everyone. We'll start with a very important topic on MSK ultrasound. Why do we need to know how to scan is for two needs actually. One is for diagnosis, the second one is for intervention. So unless you know the diagnosis, where exactly you need to put the medication or injection on, you really are not going to do any justice to doing and learning all these scanning, right? So for which you can either scan from the front or to the back. I chose to take the it's a difficult thing because you are supposed to learn it actually. So what you need to do is try to start from the long head of the biceps, right? Once you start from the long head of the biceps, that is on the anterior part of the shoulder, right? You can see a bigger, greater tuberosity which is on the left side of the screen. On the right side of the screen, it's a lesser tuberosity, and little more medially, you will see the coracoid process, right? So this is how you examine the long head of the biceps, and in between the two tuberosities, you can see the little anisotropic long head of the biceps tendon, right? Yeah, a little anisotropic because it is not perpendicular to the tendon which we are imaging. Now it is less anisotropic so that you can see the tubular echopattern. That is the long head of the biceps. Now, the moment you see the long head of the biceps, try to toggle your probe little down and up, right? This is more important because most of the times you need to fail to do the rotator interval examination, which is of utmost importance in patients with frozen shoulders, and then go down trying to see, you can see the, freeze this, yep. This is the pex major. This is the pex major which is inserting onto the humerus shaft, and you can see the long head and the short head of the biceps, right? The long head of the biceps and the short head of the biceps lying very, very close to the pex major tendon, which is the thick tendon here, which is attaching to the head, means the shaft of the humerus. I'll do it again for you. Unfreeze. The moment you see the intertubercular groove, the long head of the biceps, go down trying to look for the pex major tendon. That's the pex major tendon, and the one which I am showing you is the short head of the biceps, and that's the long head of the biceps which is closer to the humerus, right? So this is of utmost importance because patients do present with anteromedial pain. The pex major strains, patients who go for gym activities, they do present with this particular problem, pex major strain, right? Then again, going up is slightly difficult because imaging with a steady probe is slightly difficult, for which I will tell you some other technique how to visualize the rotator interval, right? Now, all the tendons, textbooks do say that the long axis examination of the tendons are of no use. Freeze this. Yeah. Could you see this? This is the long axis of the biceps. Not just in biceps, everywhere, whichever place you see a tendon, always try to look for the echo pattern of the tendon, whether there is any neoangiogenesis, whether there is any fluid, less pressure, more pressure on the tendon, then you will get to see all the structures which you want to see, and that is the importance of doing MSK scanning with respect to any tendon, not just in biceps, right? Unfreeze. So now this is biceps for you. Then going on to the, I always try to say ESSR is only a guideline, these are not set of rules to be followed, right? So I always take it next to the AC joint, not to the rotator cuff. So why do you need to see the AC joint? Freeze this image. Yes, the moment you put your transducer onto the coronal plane of the AC joint, the AC joint is nothing but, don't try to search for the AC joint, the tallest peak is the AC joint. So once you see the AC joint, place your probe on the coronal plane, and once you see it on the coronal plane, you will have the AC joint nicely visible. And 2 or 3 things which needs to be noted. Try to see which is the clavicle and which is the acromion. The higher riding bone is always the clavicle. The lower riding bone is always the acromion, right? And you can see the capsule here. Can you see? That's the capsule, right? Then your injectate can be either out of plane or it can be lateral to medial in plane. Very importantly, which I always recently started telling is, don't try to inject very close to any of these bones because these are dangerous, which can cause osteolysis of the lateral third of the clavicle, and repeated doing can result in excision of the lateral end of the clavicle. Right? This is always a possibility which everybody should remember. Either whichever be the injected, the choice of injected is yours actually. You can inject a PRP, a steroid. I always prefer a steroid. Somebody does a PRP, doesn't matter. But wherever you inject, you don't touch the bone while you inject, and it has got lot of intra-articular pressure. When you inject, you'll have to hold with both hands. Sometimes it requires an assistant to inject. So when you do it, see that you are into this particular space, not outside this space. Right? AC joint. And please. Now, while you do the AC joint, what I always say is, try to see, means you do the anterior-posterior toggling, basically trying to understand the shape of the acromion, trying to understand the shape of the acromion. If at all the acromion, freeze this. If at all the acromion is the factor which actually is the reason for the impingement. Okay? Trying to see this particular end actually is of utmost importance. Trying to see this particular end. Try to see the shape of the acromion, if there are any osteophytes inside, and if those are the reasons why there is an impingement. And you can even do a dynamic, and please, and you can do even a dynamic scarf test. Other hand, please. Okay, you can do the other dynamic scarf test where you can actually, can you see the shape of the acromion there? Please. See how far and deep the acromion lies actually, you know. This is where it is. Not normally you will see only two bones, right? Two lines, and in between one joint. You don't really understand the dynamics of the AC joint unless you do a proper dynamic examination, trying to put crossover to the opposite shoulder, trying to see the scarf test dynamic examination. Unfreeze, please. Unfreeze. Yes. Right. Now, one very important thing is, as you see the AC joint is not distended here. Sometimes it may be distended. Sometimes you can see a lot of debris inside, which is called the geyser sign, which indicates the rotator cuff material has actually leaked inside the AC joint, which means that there is an underlying pathology. There is an underlying pathology or not is actually found out by AC joint examination. That is why I prepone my AC joint examination before the rotator cuff. I may be wrong, but I do it because I can find a clue in the AC joint, right? Then, thirdly, going to the rotator cuff. All of us know that there are four things actually which needs to be seen. The rotator cuff actually, as all of you know, that it goes under the coracoacromial arch and gets inserted onto the greater tuberosity. So when it actually gets inserted onto the greater tuberosity, it's very difficult to image. So you need to get it anterior and inferior, for which you need to do the either the modified cross, right, or maybe the cross position. It's a forced internal maneuver, forced internal rotation. But are these possible in patients with severe pain? Not at all. So what you need to do, the simplest maneuver which I always do. Not many textbooks prescribe this. Just flex your elbow 90 degrees and get it extended at the shoulder. That's all you need, right? Flex 90 degrees, just a little extension on the shoulder, and you'll get to see lot of things actually, right? See, that's the, yeah, freeze this. Yeah. Now, this is the best way which I will always say examine for the rotator interval, right? The rotator interval is nothing but, you know, there are two tendons, one on the lateral side, the supraspinatus, one on the medial side, that's the subscap. It tries to go actually in the intertubercular groove, the biceps actually tends to get in front actually. So there is an interval there, that's called the rotator interval. So once you get into that rotator interval, you are actually getting an access to the shoulder joint itself. That is what is important here. Here, if you see it correctly, you will see don't think it's a calcification, it's a intra-articular portion of the biceps. It will look very, very bright, brighter than the adjacent structures. And around this particular interval, that's the interval actually, you will see black region actually. If there is a black region, generally these patients have less stiffness. The whiter it looks, the patient is likely to have more stiffness because of the fibrosis. And that is the reason why you should always prefer anterior rotator interval injections for treating recessive capsulitis rather than going only posterior. Because here you are addressing the pathology as well as getting into the joint. Whereas in posterior, you don't address the pathology that much, but in anterior, actually it's slightly difficult for injection, right? On either sides, you have got the two tendons, right? The supraspinatus more superolaterally and the subscapularis more inferomedially. So on either sides, you will have the tendon. When you actually take a good image, it should look like a tire. It should look like a tire. If there is a deflation of the tire here, or maybe, can you see this? This is the bursal surface, and you can see that's the cortical surface. If there is any, discontinuity of the cortex, or maybe some little subcortical cyst, you can see this is somewhere here, for which what you need to do is, don't keep it freeze. If you toggle your probe up and down, always try to use it 360 degrees. Never use your probe to static positions what the textbooks describe. Sometimes you will have a different patient, an unique patient, you need to examine uniquely. So always use a 360 degree examination. Try to go a little down, up, try to see if there are any cortical cysts, subcortical cysts, evidence of a glenohumeral arthritis. Right. Now you have seen the short axis view of both the tendons. It looks like a tire. There will be a deflated tire if there is a bursal surface tear, and if there is a cartilage which is seen here, that is likely to be a cortical surface tear, that is the bare cartilage sign. Unfreeze. Right. The moment you have this particular position, try to examine for the long axis of the tendon. How do you look for the long axis of the tendon? Put your probe pointing towards the tragus of the patient. Freeze this. Yeah. This is pointing to the tragus of the patient, right? Just opposite 90 degrees is your short axis examination. And once you see this particular view, what all you need to see is, one, definitely the shape of the tendon, right? It should be like a bird's beak. And the volume of the tendon, you can always compare it with the opposite side and see if there are any tears on the bursal surface or the cortical surface. Sometimes you will have a calcification here somewhere there, and if you have a calcification there, that is a normal tendon. If you have a calcification here, that's a dystrophic tendon. Okay, I'll be telling you in the later part of the day where I actually teach you about the calcific tendinitis. Then you can see there is that's a subacromial bursa. Subacromial subdeltoid bursa, that's a thin line actually. Normally it won't be seen. You can see it in patients who have pathologies, but not essentially all the patients will have a lot of fluid so that you'll be able to aspirate it. No. So it's a small stripe, which that stripe is actually caused by that little echogenicity is caused by the fat of the peribursal stripe actually, right? So this is the subacromial bursa. You can see the long axis and the short axis view of the tendons, right? Unfreeze. Very important. You should know the orientation of all these muscles and structures which you are examining prior to actually going for any scanning at all, right? The supraspinatus is arranged like this. The subscapularis is actually arranged from the anterior surface of the scapula, so that you will not be able to see unless you do a small external rotation maneuver and trying to hold the hip, hold the elbow to the hip actually, so that it doesn't get lifted off, so that you do a little bit supination and then keep it like that. And trying to examine, you can see the coracoid on the medial aspect, you can see the subscapularis on its long axis, right? And this is the short axis view of the subscapularis, again where you can see all the tendon fascicles which unite and insert onto the lesser tuberosity. That flat line is the lesser tuberosity, right? Very interesting, which I will tell you. Anytime you see any of these tendons, you always try to see all the things actually. Sometimes a small calcification at the lesser tuberosity might be the inciting factor. The moment you do this, what you need to do is, you need to do a good external and internal rotation, trying to see whether there is any anteromedial impingement or a subcoracoid bursitis or a superior subscapularis bursitis. All these are only names. Trying to see something pathological, you can very well go home and read, but if there is anything pathological, you should not miss out, right? Coming to the posterior part of it, right? Normally, we do have a difficulty how exactly, I have seen people doing, like scanning right above the spine. Divide the scapula, means like scapular area, spine of the scapula, superior means suprascapular fossa, infrascapular fossa. Just keep your probe under the spine of the scapula. You will see the head of the humerus, right? You don't really need to try to find out any other technique actually. This is the spine of the scapula, right? Can you increase the depth, Anna? Yes, yes. Freeze this image. Yeah. Okay. The bell is for me. Okay.
Yeah.
Right.
The
So this is the
session
head
is
of the humerus. You can see the infraspinatus tendon, and you can see that's the joint space, that's the labrum, and that's the glenoid. And you could see, before I actually froze the image, you could see there was a pulsatile structure there. That's the spinoglenoid notch. That's a spinoglenoid notch, and that's your target for the suprascapular nerve block or a pulse tariff. You can actually touch the glenoid, and that's for articular branch. That's for articular branch. Conventional RF, that's for pulse tariff of the suprascapular nerve. You can either, for glenohumeral joint injections, always, you can actually choose to come from lateral to medial. You can either come from lateral to medial or come from medial to lateral, whichever way you come from. Avoid trying to hit the labrum, avoid the cartilage, and most importantly, avoid the tendon also. It's a bit difficult, the needle actually bends. Actually, the needle should not bend, for which you need to have some important things which you need to adjust your things. Slightly thicker needle is always preferable. I have gone to 26 and 27, I have come back to 21 because it's easier, right? One very important thing, rather two things before I complete.
yeah, Dr. Madan Pandian, 2 minutes. I think
I will not take beyond that, don't worry. Because if I don't tell you the rotator interval and the shack, no, I think the Madan Pandian's presentation is not done.
I know.
Okay. This side. Lay down. Just down. See there, see there. Straight. Yes. Very importantly, people do ask me, how do I do the rotator interval injections? Generally, don't do any procedure sitting. Don't do any procedure sitting for all the reasons, because like it's for patient safety finally. So try to keep the patient actually slightly externally rotated, so that you will see the intra-articular portion of the biceps. Can you see this? Right? Freeze. Yes. Can somebody get the camera this side? Yeah, camera is there, right? Fine. See, now what exactly I have done is slightly keep it abducted and externally rotated, facing the palm facing upwards, so that you can be actually seated here, and you can actually do the needling from superolateral to medial. And this is where the CHI ligament is there actually. Try to pierce the ligament. A 21 gauge needle is always preferable. Don't use spinal needle because you can't have the stability of the needle. So use always a 21 gauge needle and try to inject just under the ligament, and it's sometimes very difficult because of the amount of adhesions. And see that the volume need not exceed 10 ml, the total volume. Although I do high volume rupturing, capsule rupturing technique, it's always preferable to do a capsule preserving technique 10 ml, which is there in the literature as on date, right? Now we go for the sac axis, and please, right? Shoulder anterior capsule, right? What is this? Yeah. See, to reach that, right, you can go under the subscapularis, right? That's the actual target, without actually overshooting the undersurface of the coracoid. But the problem is your needle, when it goes through the tendon, it's very, very difficult. The needle will bend and your tendon will not allow the needle to pass by. So for which we need to do a slight external rotation, possibly difficult in a patient who has got an adhesive capsulitis, but still, please. It's a bit easier because you reach the myotendinous junction. That myotendinous junction, the muscle will allow the needle to pass by. That muscle will allow the needle to pass by. That is of utmost importance. Again, the volume really need not use, means go for high end volumes actually. The 10 ml is sufficient, which is recently published by Nimish Mittal and Philip Payne. Although it is a very low number of cases actually which was reported, definitely it was proven by an arthrogram. So by literature as on date, 10 ml volume.
Thank you, Dr. Madan. As usual, wonderful presentation. We'll take the questions in the tea time, or you can meet him personally and ask these. Because of shortage of time, we will proceed further. So our next.
Thank you, Dr. Pandyan sir, for walking us through the shoulder joint ultrasound scan. Now our next topic is lumbar spine. Next we have Dr. Anand Murugeshan sir presenting on lumbar spine scanning. He is widely known for his clarity in teaching ultrasound anatomy.
Hello?
Disc space where you usually enter to get your ganglion import block done here. So it can be done using ultrasound very nicely. So that's a very big sacrococcygeal disc space, and this is your C1, and this is your S5, and this is your disc space. So the sacrococcygeal ligament comes and attaches here to the coccyx. So once you get that view done, you have to come pierce the sacrococcygeal ligament, and then one second, pointer. Yeah, this is your sacrococcygeal ligament. So from inferior to the superior, you have to get the needle here in plane technique, and then reach the caudal epidural space, and then try to not go beyond this S3, because you have got the post-acoustic shadow. So the needle will be placed exactly at the level of the S3, and then give the injection with the color flow. You can see the movement of the drug. So here there is a clinical pearl, like now you don't want to see the sacral horn here, the curved structure, which means you are in the midline. You come slightly medial here, like you can see the sacral horn of the left side, and you go slightly on the right side, you can see the sacral horn on the other side. So better to get this sacral horn away so that you will be in the middle of the sacrococcygeal space. So that's about the caudal epidural space. So for this particular model, like I'm using the linear probe for the lumbar scanning, because he's a very thin built guy. Usually you have to take a low frequency linear probe for the lumbar spine, and we have nice increase the depth please. So the first scanning technique is your parasagittal sacral crest view, where you can actually nicely see a shadow going down. Where is the pointer? So these are all the sound waves passing through the bone. So these are all the sacral foraminas. This is your S3, this is your S2, and this is your S1. So you can see the sound waves passing through the sacral foramina. So once you get the sacral foramina view, then you have to go little bit up and then get the articular process. So the second scanning technique is your parasagittal articular process view. So this is your parasagittal articular process, where you can see a camel hump sign. So you can see the camel hump sign. So this is your L5, this is your L5S1, this is your L5S1 articular process, this is your L5 articular process, this is your S1 superior articular process, this is your L5S1 zygapophyseal joint or